Hello everyone, I'm Dr. Shahnawaz Ahmed, Senior Physician from Srinagar, Jammu and Kashmir. And today I'll be briefly talking about the early initiation with the Empagliflozin and Linagliptin combination for optimal glycemic control in type 2 diabetes. As all of you know, type 2 diabetes is a progressive disorder characterized by increasing hyperglycemia and the need to gradually intensify therapy in order to achieve and maintain glycemic control. Early initiation of combination therapy has been proposed as an approach to achieve glycemic goals earlier and delay the deterioration of glycemic control with possible better preservation of beta cell function. Type 2 diabetes affected around 463 million people worldwide and 77 million in India as per ADA 2020 data, which with the predicted rise of nearly 642 million by 2040. And tight glycemic control has been shown to reduce the risk of complications, yet this is not easily achieved and maintained. And evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of micro and macrovascular complications in diabetes. Patients most likely to have reduced CVD risk with intensive glycemic control were those with a shorter type 2 diabetes duration who had not yet developed atherosclerosis. And UKPDS demonstrated a legacy effect of early intensive therapy because the difference in CV event rate 10-year post-trial was apparent, even though no difference in HbA1c level between intensive and conventional therapy. Early use of combination therapy in patients with newly diagnosed type 2 diabetes shown to reduce the progression of atherosclerosis compared with conventional therapy. Real-world evidence has also shown a legacy effect of early intensive glycemic control in type 2 diabetes. And for patients with HbA1c level more than 1.5% above goal at diagnosis, ADA and European guidelines recommended first-line treatment with dual combination and an SGLT2 inhibitor as the first post-metformin therapy. In patients with established cardiovascular disease, congestive heart failure or CKD, for patients requiring additional treatment for control of glycemia. Similar consideration should give the addition of a third agent, which may include DPP4 inhibitor, if not on GLP-1 receptor agonists or excluding saxagliptin in setting of heart failure. The use of an SGLT2 inhibitor, GLP-1 receptor agonist or DPP4 inhibitor may also be added alone or in combination in patients without atherosclerotic cardiovascular disease, heart failure, or kidney disease if there is a need to minimize hypoglycemia. EMPA and LINA combination with complementary mechanism and pleiotropic benefits may be suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease, established heart failure or CKD, due to tolerability of combination in addition to the potential benefits of empagliflozin on CV and renal outcomes, and no increased risk of heart failure with either agent. And according to study, earlier achievement of HbA1c goal, that is less than 7% with EMPA-LINA could reach targets. Following advice can be given to patients while initiating this combination. Maintaining hydration, perianal hygiene, as everybody knows, because of the glycosuria, many patients develop fungal infections or irritation. Adequate monitoring of body weight and blood pressure, blood glucose on monitoring a routine basis, informing treating physician in case of symptoms of low blood glucose. Follow the sick day rule, that is in case of feeling sick due to fever, infection, poor appetite, nausea, vomiting or diarrhea. Further evaluation in case of burning or pain during urination is required. According to recent ADA 2022 standard of care, first-line therapy depends on comorbidities, patient-centered treatment factors, and management needs. Generally includes metformin and comprehensive lifestyle modification. Treatment goal involves the control of glycemia and CV risk factor management and a patient-centered approach to care. Choice of pharmacological agent now considers the comorbidities in addition to risk of hypoglycemia, impact on weight, cost, potential for side effects, and patient preference. So early glycemic control leads to better outcomes, including a reduction in long-term macro and microvascular complications. For patients with inadequate glycemic control or metformin, Addition of single pill might be considered to help establish optimum glycemic control, while reducing pill burden and avoiding the clinical inertia in intensifying therapy. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve a target more quickly, particularly in patients with 1.5% higher targets HbA1c levels. It is reported that DPP-4 inhibitors and SGLT2 inhibitors improve beta cell mass and function via beta cell differentiation and proliferation, accompanied by decrease of oxidative stress and inflammatory cytokines. Although the mechanism of glucose lowering defect in totally it's different. In experimental study, combination of DPP-4 inhibitor and SGLT2 inhibitor exerts more beneficial effect on beta cell mass and function, especially in an early phase of diabetes rather than an advanced phase. Empagliflozin is available as first in-class treatment in SGLT2 and DPP-4 inhibitor combination group of drugs. At week 24, Empagliflozin in combination of 25 milligrams or 5 milligrams respectively showed statistically significant HbA1c reduction of minus 1.04 and add on to metformin. HbA1c decrements by Empagliflozin 25 and 5 milligram combination has demonstrated 1.81% HbA1c reduction at HbA1c baseline more than 8.5 at 24 weeks. Change in fasting plasma glucose reduction with Empagliflozin was minus 32.2 at baseline. Baseline fasting plasma glucose of 156.7 at week 24, which was maintained at week 52 in metformin treated group. Higher percentage of patients achieving HbA1c less than 7% were reported for both single pill combination versus EMPA 10 milligrams. And early achievement of goal, only fixed drug combination arm of Empagliflozin could reach target HbA1c at 12 weeks compared to monotherapy. And to summarize it all, the combination offers a suitable component and strategy to achieve target HbA1c without hypoglycemia and weight gain. Additionally, it would reduce the daily pill burden in this population and potentially improving adherence to the treatment and optimizing the benefit treatment of diabetes mellitus. Thank you very much.